Intra-renal failure. So we got some pyelonephritis is an example of intra-renal. It kind of overlaps with post-renal failure, right? When we talked about intra-renal failure, we were really thinking about ATN, right? Acute tubular necrosis, one of our most common reasons for intra-renal failure, but pyelonephritis is getting up there as well. As we start inflaming the urinary pelvis right here, it's going to start interrupting nephron function, right? So we have ascending bacteremia, for instance, and we have a complicated UTI, right? Technically, complicated UTI means you get UTIs frequently and you're like in and out of the hospital, but there's like an ascending UTI. So we're ascending and we're getting colonized by bacteria, most commonly from a UTI. That's the most common reason why you would get pyelonephritis. Pyelo meaning the renal pelvis, right? So that's this area right here. And then nephritis, the kidneys are on fire, right? So we have inflammation of our kidneys. You have a UTI being the most common reason why this would develop. So untreated UTIs or repeat UTIs could put someone at high risk for this, okay? There is such thing as descending pyelo. That's where you have a really bad sepsis, or you have like infective endocarditis, right, where you have valve involvement and untreated. That can descend down to the kidneys and it can cause pyelonephritis in that way. It's a lesser cause, but it is possible. But most common, again, is UTIs of some sort, right? So how do you get UTIs? That's their sexual activity can do it. Women are more at risk than men because of the short urethra, proximity to the anus, and men, they have a longer urethra, so it's much more difficult for them to get it. The reason why a man would get a UTI is a lot of activity and bad could be one reason, but the most common reason would be they have a catheter of some sort, right? So they had a catheter for a period of time. They also have stasis of urine, right? So bacteria love a couple things. A couple of things bacteria love are wet, moist environments, right? So we got wet environments. They also love warm environments. And they also love what else? They love alkaline environments. And they also love stasis. So stasis lets them percolate and procreate and divide. So we can get more and more and more bacteria that can divide, right? And cause infection potentially. So who's at risk for this is someone with like an obstructive uropathy. If you have an obstructive uropathy, meaning we're obstructing the kidneys in some fashion. So we have kidneys trying to dump urine into the bladder there, but there's a stone in the way, or there's a prostate in the way. There's a females don't have prostates, but females can have a fetus, right? They can have a parasite that's going to grow and grow and grow, and it can then start occluding the urinary outflow tracts, right? So you can disrupt that as well. Okay, so the pathogens from the GI tract, most commonly, the mnemonic for that is keeps, right? So the things you keep in your bowels are things that can cause UTIs, right? So Klebsiella, E. coli, gram-negative, Enterobacter, they're usually gram-negative as well. Proteus, Pseudomonas are usually gram-negative, and then we have some gram-positives. We got Staph, right? So gram-positives are purple, right? So we have also Staph aureus, MRSA, is also a risk factor for a UTI. And then if that UTI does not get treated, or they were in a hospital recently, and then they come to this hospital admission with a UTI, it could be MRSA or Pseudomonas. These are your dangerous ones, Pseudomonas and MRSA. Those cause really raging UTIs, and they're very difficult to treat. Okay, so what else? So those are the pathogens that could cause it. And if you have an obstructive uropathy, it could put you at risk. You're bedbound, you're incontinent, male or female. You have BPH, right, in men. That could cause a risk factor for UTI and development of pyelonephritis, right? And then BPH and calculi. So these guys are, what's a calculus? It's a type of math invented in the 1600s. No, it's a, what is calculi? It's a stone of some sort, right? So we're forming stones either along the pathway here, right? It's probably not in the bladder, right? It's going to be on the pathway to the bladder, right? It can also be in the renal pelvis itself, right? And as you're trying to dump urine, you're going to start, building up that urine. It's going to backflow, right? And that's going to, make your kidneys bigger, right? And that's called hydronephrosis. So hydronephrosis is a risk, is because of a obstructive uropathy of some sort. And whenever you have hydronephrosis on a CT scan or ultrasound, that's what's going to get a urologist out of bed at 1 in the morning, right? So that's always a priority to get that fixed, because if that doesn't get fixed, that kidney is going to be a high risk of dying, right? So we want to make sure we avoid any kind of further damage by taking out the source of infection, the source of the obstruction. So that's the priority at that time. There's not like a Foley catheter we can place to like drain or something. We can place nephrostomy tubes, but that's not the nurse, right? The urologist can decide, hey, this is a huge stone. We're not going to be able to get that out tonight. So let's place nephrostomy tubes, right, to reroute the urine so it doesn't become static and doesn't cause a pyelonephritis. Okay, what else? So long-term catheter use. So we'll spend a little bit with CAUTIs and how to prevent CAUTIs and what CAUTIs are. But it's a catheter-associated UTI. And how do you prevent a CAUTI? Don't get catheterized, right? That's the easiest way. So we have external catheters, right? And we have better male external catheters because back in the day, like 3 years ago, they were horrible, right? They would fall off all the time. You're like, come on, this is ridiculous, right? And we'll talk about the contraindications and indications for them. Okay. Other risk factors would be instrumentation itself. So they go in and they get a procedure done. They get a prostate procedure done. They get a cystoscopy done for stones. Ironically, can put you at risk for a UTI afterwards. Okay, even though it is a sterile process. And these guys are going to be putting out pus-like urine, pus-filled urine, right? Not pus-y urine, but purulent urine. So we'll make sure that we're charting that appropriately, but also you can see how purulent that is, right? There's a kidney obviously been taken out, and that's really high quality 4K pus that you're getting out, right? So it's infiltrated all the recesses of that renal pelvis, and it's causing a lot of pain, a lot of inflammation, a lot of damage to the kidneys. Okay, so what are you going to get? You're going to get UTI symptoms. And what are UTI symptoms? You got frequent urination. What else? Painful urination.
Bloody urine.
Maybe bloody. It's usually it's going to be bloody when you start having maybe some bacteria, but really bloody is going to be when you have stones involved. That's going to start tearing apart the lining of the urinary tract. So it could be cloudy as well, right? And purulent, and also you can have frequency. So the mnemonic is FDFF, right? So FDFF is your risk factors or your symptoms of UTI. The extra F in the front is flank pain, right? So flank pain is unique to a patient with pyelonephritis. You don't get flank pain, which is a regular UTI. When you have UTI symptoms, the FDFF, right? So you get the fever. All right, so fever should be on there as well. You got fever, you got dysuria, painful urination, you got urgency, you got frequency, you got all those symptoms, and you have flank pain. Well, shoot, now that has ascended, and now you have your flank involved, which is where your kidneys are, right? And your kidneys are more specifically located, right? You can't just say flank, you have to say is where? Costovertebral angles. Costo being ribs, vertebral being not ribs, but vertebra, right? So it's between the vertebra and the rib cage. That's where you have, and on the back side, because your kidneys are retroperitoneal, right? They're not inside the GI, inside the abdomen. Well, they are in the abdomen. They're the retroperitoneal and not inside the peritoneum. So that is one of the differentiating factors for the symptoms of pyelonephritis. But what are the labs we can do? So labs, you're going to have, if you have a fever, that means you probably have some systemic involvement. So if you have systemic involvement with a fever, you might have some white blood cells, right? And worst case scenario, that bacteria can translocate into the bloodstream, and you can have the bloodstream invasion of bacteria, or septicemia can occur from that pyelonephritis. UTIs can do the same thing. Right, so blood cultures are important, and getting antibiotics as soon as possible are also an important measure. Okay, so we talked about there being pus in the urine, right? So you got pyuria, you got cloudy turbid urine, but just because you have turbid urine does not mean you have a UTI. So there's something called sterile pyuria, right? So versus sterile pyuria. So you can have just pus in the urine, but there's no bacteria to be found, right? So, or not enough to cause an infection. So this is something discovered in the last, 15, 20 years where, it avoids the overuse of antibiotics, right? And it avoids any kind of unnecessary instrumentation, because sometimes patients have a Foley that has this, and they're like, oh shoot, take it out, let's put another one in, or let's take it out, and let's just, and then they have incontinence, and it's a whole downward spiral from there. So, we have to make sure they also have diagnostics that support they have a UTI. They have to have symptoms first, right? So they got the fever, urgency, dysuria, and such, and they got cloudy urine. Well, that's kind of really leaning towards someone that has a UTI. But what else really tells you have bacteriuria, right? So it's like back to school night. All right, so bacteriuria, you got bacteria in the urine. How do you know? You can culture it, right? You can do a urine culture, right? So we're gonna do a urine culture as well. Urine culture, right? Is also a good idea, but you're not gonna get those results for how long? Couple days, right? But we're going to do a sample. We're going to use our forensic skills, and we're going to dust for prints, right? And how do you dust for prints? You see that if there's some nitrate reduction happening, right? So nitrates get converted into nitrites only in the presence of bacteria. There's no other process in the body that does this, no other process in nature that does this. Bacteria are the only things in known universe that do this, right? So we have nitrite positivity, right? Nitrite's positive, you got a 98% chance you got a UTI, right? So whenever you look at a UA, the first thing I'm always looking for is where are the nitrites at, right? Nitrates are positive, bam, you have a UTI. Congratulations, right? What's really going to seal the deal is that they have the symptoms, and also they have some urine WBCs. So urine WBCs greater than 10 points, all right, that's going to be a high risk for UTI as well. Because yeah, you could have nitrite positives, but it's not quite causing the UTI just yet, right? But it's something to be alert to. The other thing that really seals the deal is leukoesterase. So leukoesterase positivity or nitrite positivity. You're not going to have both. You have one or the other. And leukoesterase is an enzyme secreted by neutrophils. And what do neutrophils do? Their one only job is to do what? To kill bacteria, right? They're the white blood cell division that kills bacteria. So they've been around, right? You're looking for like shell casings that they fired off at bacteria, right? And that was something to ester, right, to break down lipids such as the cell membrane or cell wall of a bacteria. So leukoesterase positivity can tell us also that we have a bacterial infection of some sort, right? So we're gonna do blood cultures. We're gonna look at this, CBC for white count. We can look for cloudy urine, but cloudy urine is not what tells us we have a UTI. What tells you have a UTI is when you have white blood cells and one of these two things, nitrite positive or leukoesterase positive. Hematuria might be there, especially with stone, right? That's gonna be a high risk for maybe the stone is what caused backing up of this urine, and then that caused a UTI to develop. Okay, and then if it's urine's backing up, what develops? All this, you got a stone right there, all this stuff backs up, and what happens? You get stasis and hydronephrosis, right? So if you have hydronephrosis, how do you know you have hydronephrosis? You've done a CT or ultrasound. That will tell you you have hydronephrosis, right? So it's all usually when someone comes with a UTI, especially being admitted to the hospital with a UTI or the ICU with a UTI, we definitely should be getting CT scans and renal ultrasounds to make sure that it's not worst case scenario, a stone that's blocking the outflow or BPH is blocking the outflow, right? Because that can percolate a lot faster, where the bacteria are going to keep dividing, and that can cause a rampant UTI. Yes, UTI, but a rampant septicemia as it spreads up into the bloodstream, right? It's going to go right into the bloodstream. Okay, so how do you treat this? Antibiotics are the go-to, right? Get them as soon as possible. Pain meds, this is very painful. So are NSAIDs a good option? No, because NSAIDs are going to, they're going to vasoconstrict the afferent arteriole, and they're going to impair, renal flow. They're also going to cause damage to the kidneys themselves. So we should not give NSAIDs. So ideally, we should be giving a Tylenol is just fine, but this is a urinary analgesic, phenazopyridine or pyridium. That would help with the burning pain. The costovertebral angle pain probably won't be helped too much, but we can always give, we can use our ladder of pain meds to help out, right? Giving IV push opiates if we have to. Okay, and then surgically we could place a nephrostomy tube to reroute the urine from causing hydronephrosis or from being static and into just a Foley bag that we can measure on the side, a little leg bag, right? What else? So we have a nephrostomy. We might have to do a nephrectomy or take out part of the kidney, right? Or we might have to do stenting to keep part of the urinary tree open. Okay, because sometimes with stones or with poor reflexes or like neurogenic bladders and all these other things that could cause a inadequate flow of urine, sometimes they need help keeping this open and stented so that we have good urine flow in the end. Okay, so other things to compare like urine WBCs. Urine WBCs you might also see with like some inflammatory processes, when someone has like a sulfa allergy, when someone has like an allergic response, when someone has inflammation of the kidneys, you might see white blood cell casts as well. Will you see leukoesterase? No. Will you see nitrites? No. So that's where, pyelonephritis is really going to be showing it's going to be kind of seal the deal for someone that has a UTI or pyelo. Okay, so urine RBCs or urine heme, right? So urine heme will be positive in what situations? When there's a heme present, of course. Why you even ask me silly questions, right? So heme is present in what two conditions? You got stones that are irritating and scraping and along the urinary tract. That could cause hematuria, and you're going to have some RBCs present because you're breaking apart that urinary tract, right? And also, we just talked about rhabdo, right? So rhabdo will have a myoglobin that makes its way to the nephron, but it blocks it, right? And if it blocks it, it causes acute tubular necrosis. It causes muddy casts, but it also causes a heme-positive urine without RBCs. Okay, so rhabdo is heme-positive without RBCs. Right, and we touched on hemolysis just briefly. That's like with tumor lysis syndrome. All right, and then what else? So acute tubular necrosis has these like characteristic muddy brown casts. That's like a classic presentation that you would look on the UA and says, oh, you got muddy brown casts. Well, that's acute tubular necrosis. There's nothing really else that causes that, right? There are other things that cause urine WBCs. There's other things that cause urine RBCs, right? Because sometimes when our glomerulus is damaged, right, a little big glomerulus right here, all right, the glomerulus, if things are spilling in there that shouldn't spill in there, such as RBCs and proteins, right? So proteins and RBCs, those should not be spilling into our urine, right? You should not be bleeding spontaneously, all right? That should not be a thing. And then you should not be peeing out protein because otherwise your urine will be super, super frothy, right? So when you are doing that, you have frothy urine because you're in really profound kidney failure, like chronic kidney disease, or you have glomerulonephritis. Your glomerulus is inflamed, right? It's being attacked. It's being attacked by strep, or it's being attacked by lupus, or being attacked by even hypertension damage over time with chronic kidney disease, right? So you're going to start spilling blood and protein into the urine, okay? And we're going to be able to see that. And they'll do more tests to figure out, oh, do you got lupus, right? Do you have a recent strep infection, right? So strep is classic for causing a glomerulonephritis. So that's the idea behind pyelo, is that we're looking at the symptoms of what? FDFF, right? All right, so what are the symptoms? Fever, yep, because we got white blood cells elevating. You got some flank pain or costovertebral angle pain, CVA pain. So my stroke is hurting. No, I have costovertebral angle pain. I got some, what else? FDFF, D for dysuria or painful urination. I can use pyridium for that. I can escalate that to some opiates. And just what are some other opiates you should not give for renal? Morphine. Morphine's metabolites will build up and cause some damage to the kidneys, which we don't want, causing seizure activity and causing rhabdo, right? So we want to give pain control for the dysuria, and then we have what's the U? Urgency, right? And for an ICU patient who's intubated and sedated, it's hard to assess urgency, but we have to be alert to the other symptoms around the what we expect for UTI, and we can, a UA does not lie. So that's something that can help us figure out that it's a UTI that's developing. All right, so post-renal failure. So pyelonephritis, yeah, can cause the post-renal failure, and it's kind of that overlaps a little bit with intra-renal failure. But here we're kind of talking about those obstructive uropathies. We're getting that hydronephrosis that's developing because our kidneys are making urine, but it's not able to get out through the urethra. So there's a renal pelvis blockage, right? Or there's a ureter blockage, or there's a urethral blockage from a prostate, right? And for bladder blockage, you'd have to block it on both sides for it to actually cause, cause kidney failure. It's going to cause a lot of pain, a lot of UTI symptoms and such, but for you to actually develop post-renal failure, you'd have to have both sides blocked. But, obviously you can see the stages here of hydronephrosis, and you really get swollen, cause a lot of damage, right? So here we got a stone there, right? So one of the things that we can avoid is make sure that our Foley is flushed, right? Make sure that we don't have a bladder that is full and at risk for hydronephrosis. So how do we know that? We can do a bladder scan, right? Bladder scan is good, or I have no urine output, and really kind of the first step in the next question someone's going to ask you is, did you do a bladder scan? If I have no urine output, right? So he's like, I've been with them for 12 hours. I saw it was 100 at the beginning of my shift, and now it's 10. Nothing's changed. So they're still going to want you to do a bladder scan, right, to make sure there's not any kind of increased retention, right? Because we know worst case scenario, it can lead to pyelonephritis, which is bad news, right? And sometimes your patients come back like with a post-TURP, right? They have a post-transurethral resection of the prostate, and it has a lot of complications in of itself. But one of the primary complications is clot formation, right? So clots can form, and clots can block things. Like in neuro, it blocks the flow of CSF, and in renal, it's going to start blocking the flow of urine, right? So if we have all this clot forming here, whether you have a catheter or not, right? You might have a catheter clot that clots over the tip of it. That's going to cause a backup of urine. So we have to give do we give like T and K for it? No, you don't give thrombolytics via the bladder, but you will have to flush it and irrigate it, right? And usually we use a huge bad boy catheter, right? It's like a 24 French, 26 French even, maybe something 28 French. So those are huge, like garden hoses, right? So you can scare some people, and you see like, this is what we're gonna have to put in, and you know the worst, the consequence if we don't put it in might be worse, right? As we back up and cause possible post-renal failure. Okay, so ultrasound will tell us if we have any kind of hydronephrosis. Usually a CT scan will be needed to see if we have any kind of blockage along the ureteral tree. It's more difficult to see that on ultrasound. All right, and then we can avoid urinary backup by avoiding medications that block the flow of urine. All right, so we have alpha receptors that are located, alpha-1 receptors that are located on our kidneys, right? We have alpha-1 receptors, as we know, for like renal perfusion is concerned, right? When the SNS fires off, it binds to beta-1, beta-2, and alpha-1 receptors. When it binds to alpha-1 receptors located in the arterioles of the GI skin and renal, right, it's going to vasoconstrict and raise our blood pressure, right? Kidneys don't like that. They're going to start releasing the RAS afterwards to try to get some more sodium and water to kind of fix the situation. But if you bind to an alpha-1 receptor, you cause what? You cause a rise in blood pressure, and you cause vasoconstriction, right, to the kidneys. And yes, you're at risk for kidney damage eventually, but you know, initially you're going to have symptoms of urinary retention. It's not time to pee when you run away from a bear. So right now the time is to reroute blood and not pee, right? Usually you pee because you get scared, right? But as far as if you have your wits about you, you shouldn't be peeing. Okay, as you're running away, you should not be urinating. All right, but we have alpha-1 receptors also not only on the arterioles, but we also have them on the bladder neck and the prostate. So you bind to the alpha-1 receptor right here. So if we bind there, right, with an SNS action or with other chemicals that might bind, we have other things involved as well, but we have binding to that prostate or the bladder neck, that's going to cause urinary retention. Okay, so we give alpha-1 inhibitors, or they're called SNS inhibitors, or SIN, right? So SIN, like tamsulosin, right, is something that's going to inhibit the bladder neck from contracting, right? So like Flomax, tamsulosin, it promotes bladder emptying because it's going to inhibit those alpha-1 receptors. One of the side effects is that we have a drop in blood pressure, right? So that's one of our side effects of those prostate drugs or those Flomax drugs, SINs, right? So other things to take note is midodrine is a alpha-1 agonist, right? Alpha-1 agonist, it stimulates it. And that's great. It's going to raise our blood pressure. Perfect, right? That's why we give midodrine, so we can get them out of the ICU sooner. Hopefully we can prevent them from getting added back on depressors. But midodrine, you'll have a patient always complaining that I can't pee, right? I got bladder pain, I can't, or I got lower abdominal pain, I can't pee. And sometimes people can't figure it out. So I don't know what's going on. And they'll add tamsulosin. It's like, what are you doing? You're giving alpha-1 inhibitor and alpha-1 agonist? How is that going to work out, right? So it's something to pay attention to when you give midodrine. They might have this urinary retention symptoms. Okay. So what else? Other drugs that might cause the bladder neck to contract are acetylcholine, right? So acetylcholine causes the causes the bladder to relax, right? So if SNS causes it to constrict, the PNS, right, the parasympathetic, is going to cause it to what? Rest and digest and pee, right, is the job of the parasympathetic, right? So the parasympathetic uses what hormone? What neurotransmitter? Acetylcholine. So if you give a anticholinergic, that's going to cause what? Urinary retention or urinary flow? cause retention, right? So you have to be alert to that as well. Someone's complaining of urinary retention. It could be some of the anticholinergics they're on. It could be antipsychotics that might be on, right? Antidepressants like amitriptyline and such. And it could be just straight up Benadryl. Benadryl has anticholinergic properties as well. It's antihistamine. It's also anticholinergic, right? And just straight up anticholinergics that we give for people that have overactive bladders, right? That empty just at will. It's like they take medications to stop it. So there's just two really, oxybutynin and tolterodine. Those are the ones that you'll see on the profile. Oh, that's why you have urinary retention. Okay, they might have been taken for good reasons, but we have to be alert to that. Okay, and then what else can cause urinary obstruction and then cause post-renal failure would be something that's forming crystals. So we have acyclovir. It forms like the most jagged crystals you ever saw, right? It's literally like like Superman's cave, right? What's it called? No, yeah, kryptonite's not his cave. That's a bad choice.
Oh, sorry.
Cave of Wonders? No, that's from Aladdin. Anyways, we have like huge crystals that are going to be causing a lot of damage and a lot of bleeding as it's making its way on out of those ureters, right? Methotrexate causes stone formation, and sulfa drugs. They not only damage and cause inflammation of the kidneys, causing acute interstitial nephritis and ATN, but they can also cause post-renal failure because they form crystals in the renal pelvis. So that's something to be alert to when you're giving these medications that put them at risk for renal failure, specifically post-renal failure.